All right, welcome. Today, we're diving deep into a clinical investigation of puerperal fever. It's a major player in postpartum morbidity and mortality, so it demands our full attention. So let's get our terms straight. Puerperal fever, or puerperal sepsis, is essentially an infection of the genital tract that kicks off after childbirth. Now, it often starts out looking like endometritis, but the real danger, and the reason we have to be so vigilant, is its potential to just explode into systemic sepsis and shock. It's something that requires a very high index of suspicion.
Here's how we're going to break it down. First, we'll look at the clinical signs, what this looks like on the ground. Then, we'll get into the detective work, identifying the microbial culprit. After that, we'll talk strategy, the right antimicrobial countermeasures. We'll also cover containment and prevention. And finally, we'll look at a case study of what happens when complications arise.
Okay, let's get into Section 1, the clinical manifestations. Recognizing the initial presentation is absolutely key for early and effective intervention.
So, when are we most likely to see this? The clock really starts ticking right after childbirth. Symptoms usually pop up within the first 8 days, but the peak danger zone, the time we see fever and abdominal pain most often, is really within that first week. Any fever in the postpartum period should raise a red flag, but this timeline shows you when to be on highest alert.
All right, Section 2. Now for the forensic part of our investigation, identifying the microbial culprit. Getting the pathogen right is obviously the foundation for any targeted therapy.
The protocol here is non-negotiable. Step 1, and this is critical, you have to get your cultures before you start the antibiotics. If you suspect endometritis and the membranes are intact, a high vaginal swab is what you need. But if you're seeing systemic signs, fever, chills, the whole picture, you need multiple sets of blood cultures to give yourself the best shot at isolating the organism responsible.
And here's our lineup of the usual suspects. The list is pretty broad, right? But the one we're most concerned about, the one that keeps us up at night, is Streptococcus pyogenes, or group A Strep. That's because of its nasty link to severe invasive disease and toxic shock syndrome. But you can't get tunnel vision. Group B Strep, Listeria, and your gram-negative bacilli are also really common, which just drives home the point that you need broad, empirical coverage until you get those culture results back. Section 3. Okay, we've identified our suspects. Now let's talk about the antimicrobial countermeasures. This is where we bring out the heavy hitters. Now, this is where the strategy gets really nuanced. You can see we tailor the IV regimen based on how severe the clinical picture is. For that dreaded gas-associated toxic shock, a two-pronged attack is absolutely essential. You hit them with a beta-lactam, like benzylpenicillin, to attack the bacterial cell wall, but you also add clindamycin. Why? Because clindamycin is brilliant at shutting down the toxin production that's driving the shock. And notice for the most severe cases, we're using high-dose, continuous infusions to make sure that drug concentration stays above the MIC. As for duration, you're typically looking at 7 to 14 days, but you let the patient's clinical response guide you. And of course, the investigation doesn't stop with the mother. The implications for the neonate are huge. If you suspect early onset sepsis in the newborn, the go-to empirical combo is ampicillin plus gentamicin for that broad coverage. If it turns out to be group B strep, then you can narrow that down to IV benzylpenicillin. Section 4. Containment and prevention. Because treating the individual case is one thing, but we also need a public health strategy to get ahead of this. So how do we contain this? Well, it's a multi-pronged approach. First, this is a notifiable disease, which means reporting is mandatory for surveillance. On the patient level, prevention includes things like antibiotic prophylaxis during labor for mothers colonized with GBS, and of course, routine maternal vaccinations. But you know what the absolute cornerstone is? The simplest thing? Rigorous hand hygiene by every single person on the clinical staff. It's fundamental. Okay. Even in the middle of a serious clinical breakdown, you gotta have a little moment of levity. Why did the bacterium break up with the fungus? Because there wasn't much room for their relationship to grow. Right, bad jokes aside. Let's move into our final section, looking at a case study of complications. This is where we see the incredibly high stakes when diagnosis is delayed or the pathogen is particularly nasty. The maternal complications can be just devastating. We're talking about a spectrum from severe sepsis all the way to, tragically, maternal death,
especially when invasive group A strep is involved. And it doesn't even stop when the infection is gone. We have to worry about post-infectious immune-mediated problems. Both acute rheumatic fever and post-streptococcal glomerulonephritis are caused by this phenomenon of molecular mimicry, where the immune system gets confused and attacks the body's own tissues, potentially leading to lifelong heart and kidney damage.
Okay, let's put it all together with a quick self-assessment. Based on all the evidence we've just discussed, when you see a severe case of puerperal fever with toxic shock, who is your #1 suspect?
And the answer, of course, is Streptococcus pyogenes. This really brings home that critical therapeutic point we talked about earlier. Managing this beast requires that dual-agent approach. You need the beta-lactam for its bactericidal firepower, and you need the protein synthesis inhibitor, like clindamycin, to shut down the superantigen factory that's causing the toxic shock. That synergy is absolutely essential for a good outcome.
So this leaves us with one final and really critical question. Puerperal fever is an age-old threat, but our microbial suspects are constantly evolving, especially with rising antibiotic resistance. The question we have to ask ourselves is this: how are we going to adapt? How will our investigative and therapeutic strategies keep pace to protect future mothers from this formidable enemy? It's going to demand constant vigilance and innovation.